Welcome to Cancer Coach Live. Today's program is Facing Triple-Negative Breast Cancer, Self-Advocacy, and Decision-Making. My name is Ricki Fairley, and I'm the CEO of Touch the Black Breast Cancer Alliance and a 10-year survivor-thriver of triple-negative breast cancer. I am joined here today by two of my favorite docs, Dr. Tiffany Traina, Vice Chair of Oncology Care and Section Head of the Triple-Negative Breast Cancer Clinical Research Program at Memorial Sloan Kettering, and Dr. Lori Wilson, Chief of the Division of Surgical Oncology at Howard University Hospital. This program is presented with the National Breast Cancer Foundation and my foundation, Touch the Black Breast Cancer Alliance. It's supported by an educational grant from Gilead scientists. So we'd like to hear from you during the program today, so please take a moment to ask your questions. Just type them into the box below at any time during the discussion. And please keep in mind the questions should be general in nature. We're not able to answer questions about your specific case, but we encourage you to bring these to your doctor. Please see the event resources section of the player located under the video box to download today's presentation and some additional resources that we're providing. We will also be asking some polling questions throughout the program, and we encourage you to respond as it will provide insight into your experience and drive our discussion today. These are our disclosures. Today, we will cover topics including understanding triple-negative breast cancer. It's a very complicated disease, some treatment options that are available to you, and collaborating with your care team. The Cancer Coach Live team recognizes that participants in this activity are diverse in representation, including different races, ethnicities, cultures, and environments. For the purpose of our discussion today on race and ethnicity, we basically are going to use the following terms just to clarify that. So women of color represents non-white American women. Black/African represents women of the African diaspora. Hispanic/Latina represents women of Hispanic and Latino origin. American Indian/Alaska Native are also included here. So to start off, let's discuss TNBC to help us understand it better. So before we do that, we're going to take a quick poll. So have you ever asked, so the polling question is, have you ever asked the treatment team about what factors may affect your prognosis or your expected outcome of triple-negative breast cancer? And there are 4 answers to choose from. I feel comfortable asking my team questions. No, I researched this on my own and through advocacy groups. C, no, I do not feel comfortable asking the team about these questions. And D, I'm not interested in knowing about factors affecting prognosis. So while you're thinking that answer, I'm actually going to turn this over to Dr. Traina, who is going to start to talk about triple-negative breast cancer.
Great. Thank you so much. It's a pleasure to be here with everyone. And for the next few slides, I thought we would just do some level setting and really defining what triple-negative breast cancer is. So oftentimes you'll hear that triple-negative breast cancer is the most aggressive subtype of breast cancer right now. And I think it's earned that reputation for a couple of reasons. One, it can have a rather rapid growth rate. It is often more likely to have spread to other organs outside of the breast or lymph nodes by the time that it's originally diagnosed. It is at a slightly higher risk of recurrence of disease after a diagnosis of early stage breast cancer, that we do sometimes see it come back more often outside of the breast. And it has, although traditionally responded to our available chemotherapies, perhaps less so than the response we see from some of the other subtypes of breast cancer. Now, triple negative earned its term really by being defined by what it lacks. And that refers to two of the hormone receptors, estrogen receptor and progesterone receptor, and the third being HER2. So I really encourage you to ask these details of your care team and your doctors. When your cancer tests negative for estrogen, progesterone, and HER2, it is often called triple negative. And these receptors are really important because there are therapies targeted for those receptors. When we're missing expression of those receptors, it means that those hormonal or HER2 targeted therapies are not effective. But I will say that we're in an age and a time right now where we do have other effective treatment options for triple negative breast cancer, and we'll come to that in a couple of moments. Just some other key facts to be aware of for triple negative breast cancer are shown here, and we'll go through them one at a time. You know, triple negative breast cancer is relatively uncommon. It only accounts for about 10 to 20% of all the breast cancer that is diagnosed in the United States. As I alluded to before, often women are diagnosed with triple negative breast cancer at a more advanced stage than perhaps hormone receptor positive or HER2 positive breast cancers. Women who have a hereditary predisposition to breast cancer, particularly BRCA1 mutation, are at a higher risk of developing breast cancer, and specifically triple negative breast cancer. And we talked about why it has earned this reputation of being a more aggressive subtype of the disease. You know, unfortunately, historically, women with triple negative breast cancer have not responded to anti-estrogen or hormonal therapies, and they have not responded to HER2 targeted therapies. And so traditionally, we have really been limited with chemotherapy as our sole option for treatment here. We did talk about how triple negative breast cancer patients do have a bit of a higher risk of recurrence of their disease. And by that, I mean a recurrence somewhere outside the breast or lymph nodes, something that we would call metastatic breast cancer. Unfortunately, when patients have advanced triple negative breast cancer, metastatic breast cancer, this remains a treatable, but unfortunately not curable disease today. Although I do want you to come away from this program hearing how exciting the area is right now and how we have such innovative new therapies to treat and improve cure rates of triple negative breast cancer. But patients with triple negative breast cancer do have a higher risk of death compared to other subtypes of breast cancer. So how about a little bit more of who gets triple negative breast cancer? There are some patterns and differences between triple negative breast cancer and hormone receptor positive or HER2 positive breast cancer. Women with triple negative breast cancer tend to be younger at diagnosis. So on average, even under the age of 50. And race and ethnicity is important here. We see that women of color are disproportionately affected, African-American women and women of Hispanic and Latina backgrounds. Often there may be a family history of triple negative breast cancer. And again, that relates to that hereditary BRCA1 mutation that can predispose to a risk of triple negative breast cancer. So race and ethnicity matters. And as I just mentioned, women of color are disproportionately impacted by triple negative breast cancer. And we have some of the stats here as compared to women who are white or Caucasian. So Black and African women are 2 to 3 times as likely to develop triple negative breast cancer and 40% more likely to die of their disease. And this is an area that needs attention. We want to spotlight this and really make a difference and impact here. The majority of patients are diagnosed under the age of 45. And as we said, at a higher stage of disease, stage 3 or 4, compared to other racial or ethnic groups. And women of American Indian or Alaskan Native are at higher risk as well to develop triple negative breast cancer at 1.3 times what we see with white and Caucasian women. Hispanic and Latina women have a higher risk at 1.2 times that of white or Caucasian women. So I think that these are critically important features to understand the patterns in which we see triple negative breast cancer. And it is critically important to advocate for yourself. So there are other socioeconomic factors that can affect outcome once diagnosed with breast cancer. And this includes having access to healthcare, having the financial or physical resources to receive therapy. So whether that means adequate insurance coverage or even transportation to appointments or flexibility to be able to have time off of work or employment to access therapy. And it is critically important to be diagnosed in a timely fashion and have the appropriate testing, both screening and diagnostic testing. So these are really, really important factors. Uninsured women have a higher mortality risk than those who are insured, 60% versus almost 30%. And this is something that we should be empowered to change. Black and African women are about a third less likely to be referred for genetic testing. And you've already heard that having a hereditary BRCA1 mutation predisposes to develop triple negative breast cancer. So we need to be sure that you are empowered to have this information to be referred for genetic testing and to know the BRCA1 or 2 status for yourself and your family. So how can your voice make a difference? How can you take action? How can you be empowered? I think it's important to receive the appropriate testing necessary. That will inform the kinds of treatments that are available and appropriate. It is key to advocate for insurance coverage for appropriate tests and treatment. And your treatment team can help here. There are patient navigators and social workers and your clinician care team and financial counselors that are all there in your corner to help advocate for you. It is key to increase awareness amongst family members and community members and to do that routine health screening. Don't let your mammogram be postponed, even in the setting of a pandemic. It is important to keep up with that screening. And honestly, to prevent triple negative breast cancer from being dismissed due to age or race, right? Remember, I did mention triple negative breast cancers tend to be diagnosed in younger women. So if something doesn't feel right, escalate that, advocate for yourself and to your care team. So triple negative breast cancer is often diagnosed later than other types of breast cancer. As I said, later, meaning even a more advanced stage 3 or even stage 4. And so it's important to have an awareness of what testing should be received to help inform treatment. From a diagnostic standpoint, having your screening mammograms is critical. This includes modern technologies such as digital mammograms and MRIs where appropriate. So patients that have a high lifetime risk of developing a breast cancer are candidates for MRI. Certainly patients with a hereditary BRCA mutation are candidates for MRI screening. There are blood tests and tissue tests that are important once there's an abnormality seen to diagnose breast cancer, to stage breast cancer, and to understand, again, what those hormone receptors show and that HER2 receptor shows. And key is that genetic testing. A diagnosis of triple negative breast cancer really mandates having hereditary genetic testing because this is important. Personally, it's important to help guide treatment, and it's important for risk and for your family to know. So I'm going to move on to the next section. And let's presume someone is faced with a diagnosis of triple negative breast cancer. And a natural question to follow is, what do I do about this? And what are my treatment options? So before we jump right into that, we're going to have another poll and encouraging you to participate here. When discussing treatment decisions, what is most important to hear about from your healthcare team? So is it results of biomarker and genetic testing? And that's both tumor genetics as well as hereditary genetics. Is it the impact of treatment on quality of life? Is it the possibility or risk of a recurrence of breast cancer? Is it the benefits and risks of each treatment? And lastly, is it consideration for a clinical trial? And we're going to leave these options up here for you. I know it might take a little bit of time to answer, but we'll come back to those responses once we've got everybody's results tallied. So jumping right into how treatment is selected. As a medical oncologist, I exclusively care for women who have a diagnosis of breast cancer. And I have to say that there are many, many factors that are important in making a recommendation for treatment. Foremost is really what stage of disease are we talking about? Anywhere from stage 1 to 3 would be considered early stage breast cancer, and stage 4 would be considered a bit later stage of breast cancer. And this is important in understanding what our goals of care are and what our treatment options are. I would say on the left, subtype of triple negative breast cancer is important. So triple negative breast cancer is really a basket term. And within that, there are additional subtypes that may have different biology. So really trying to understand that nuance is critical, and asking your doctor about that. Understanding what prior therapies somebody may have had for their breast cancer is key. Whether you have triple negative breast cancer or hormone receptor positive breast cancer, knowing what therapies this cancer may have seen, what resistance may have developed, and what lingering side effects there may be from past therapies, like numbness and tingling of fingers and toes, or potentially heart impact of past therapies. All of that is really important because we really want to make sure that our treatment and our side effects are never worse than the cancer. A patient's underlying medical conditions are really key. So as I mentioned, neuropathy or nerve numbness and tingling is one of the side effects for many of our drugs. And if somebody has a predisposition, already has neuropathy from perhaps advanced diabetes, that might be a consideration in recommendation and treatment choice. And at the heart of all of this, right there in pink, is patient preferences. And that cannot and should not be underestimated. So there are different treatment schedules. There are different side effects with regimens. Some we have evidence for that were clearly better than another against the breast cancer. But other times when all things are equal, having patient preference around side effects, logistics, and what fits into a woman's life as she's living life while being treated for her breast cancer is really important. And I would encourage you to not be shy and have these conversations about what's meaningful and important to you with your care team. When we talk about treatments, they can be divided into two categories. Those that are already FDA approved, meaning they have been through robust clinical trials compared to some standard of care, deemed to have high activity and a reasonable side effect profile, and they are endorsed by the FDA. There are also drugs that are investigational, really novel and new, and working their way through clinical trials to determine safety, appropriate dosing, and activity and benefit. So that is one of the ways to categorize treatments. What is FDA approved and considered a standard of care, and what might be investigational and novel. In addition to systemic treatments that go everywhere in the body, like chemotherapy or immunotherapy, we have surgery as a treatment option, as a very important option in early stage disease. And we have a very new class of medicines called antibody drug conjugates that we'll talk about. So along with surgery upfront for treatment of an early stage breast cancer, some of the additional modalities for therapy include radiation and also chemotherapy. And chemotherapy are drugs that are often intravenous, but there are some pill versions. This medicine goes everywhere in the body. And as I think about it, it's able to attack those cancer cells wherever they may be hiding out that might be invisible to the eye. Some of the drugs that you might hear about for treatment of triple negative breast cancer are listed below here, and they include platinum drugs like carboplatin or cisplatin. And there are also classes such as taxanes like paclitaxel or docetaxel. There are anthracyclines, and there's a list of other medications shown there that all have activity in breast cancer. So I do want to just take a moment because we've gotten the results in from our poll a few slides back. And the majority of folks have answered option B, which said it's really important to you to know the benefits and the risks of each treatment. And that resonates for me. And I think that these are very important questions to ask your care team. I would say all of the features that were on that slide are important to have a discussion about with your care team. So in the next couple of moments, I'd like to go over some of the new exciting therapies to treat more advanced triple negative breast cancer. And one of these is immunotherapy. Now, immunotherapy helps your own body's immune system recognize the cancer cell as something that doesn't belong and helps recruit your body's defenses to kill that cell. So there's a cartoon on the right that I'm going to just sort of show you how that works. The yellow circle there is a tumor cell, and that bluish purple graphic is your own body's T cell, which is one of your immune system cells that attacks and kills foreign things. And when the T cell recognizes the tumor cell, there is an interaction there where the tumor suppresses your own body's immune system to kill it. So there is a new class of medications called checkpoint inhibitors that disrupt that interaction. And it essentially revs up your own body's defenses and allows those T cells to kill the cancer cell. So Pembrolizumab is an FDA-approved immunotherapy for triple-negative breast cancer, and it has approval both in metastatic triple-negative breast cancer when combined with chemotherapy, in a subset of patients that have a biomarker, something called PD-L1, to help predict benefit from this agent. And then separately, it just recently received FDA approval to treat early stage triple negative breast cancer, also when combined with chemotherapy, in patients that had either larger tumors or involved lymph nodes. Now, there can be side effects from unleashing the body's immune system, and these are called immune-related adverse events. I would encourage you to talk with your care team about what to expect if immunotherapy is recommended for you. Another really new exciting opportunity for treatment of triple-negative breast cancer are a class of medicines called antibody-drug conjugates. So now the construct for an antibody-drug conjugate uses an antibody, which shown here on the graph is this little green upside-down Y-shaped graphic. So an antibody travels throughout the body and finds a target, right, that it is directed towards. And our bodies make antibodies to fight foreign things, but here we've been able to engineer antibodies to help recognize cancer cells and kill those cancer cells. Here, an antibody is designed to a target on a triple-negative breast cancer cell. That target is called TROP2, and it is linked to a few molecules of a chemotherapy drug. So rather than just giving all of that chemotherapy directly into the vein in not a very targeted approach, these antibody drug conjugates deliver the molecules of chemotherapy right to where they need to be, right to the cancer cell. So Sassachuzumab Govatikan is shown here in this graphic, and this is one of the antibody drug conjugates FDA approved to treat triple-negative breast cancer. And I'll highlight that that target, TROP2, is highly expressed in triple-negative breast cancer. And so you do not need to have your tumor tested for the presence of TROP2 because it is essentially there in nearly all triple-negative breast cancer. And that's exciting news. So here's a little bit more information on antibody drug conjugates. We talked about how their targeted delivery of chemo right to the cancer cell. Sassachuzumab Govatikan, or otherwise called Trodelvy, is approved for patients who have metastatic triple-negative breast cancer who've had 2 or more prior treatments for their disease. And this drug, when tested in a big randomized phase 3 trial, showed improvement in overall survival for women compared to all the other chemotherapy drugs that we had as standard of care for treating triple-negative breast cancer. And that's a really impressive outcome to improve survival. Now, there are some side effects. What we see most commonly is that this antibody drug conjugate can lower blood counts. So when you lower the white blood cells, folks are a little bit more vulnerable for infection and might require some booster shots to help recover more rapidly. The other side effect we see commonly is diarrhea. And yet this is something that can be managed. There are medications over the counter that can be taken to prevent diarrhea. Sometimes some dietary adjustments can help. And so it is really important to talk to your doctor if you're receiving Sassachuzumab on how to monitor and manage those side effects. There are also several other antibody drug conjugates in clinical trials right now. They're a bit of a mouthful. You can see them there on the slide. That first one that we affectionately call Dato-DXd also targets TROP2. Now, this drug is much earlier in development. Remember, we classified treatments as FDA approved, standard of care, and others that might be investigational. Dato-DXd is an investigational antibody drug conjugate available through clinical trials right now. The second agent that's shown there on the list is another antibody drug conjugate directed towards something called ROR that is expressed as again, a receptor on the surface of cancer cells, and it is linked with a payload or a chemotherapy as shown there. Enfortumab vedotin, another antibody drug conjugate, same toxin attached to it, but the target is different. This target is something called Nectin-4. This is also in investigation right now in a phase 2 study in patients with triple-negative breast cancer. And then lastly, trastuzumab deruxtecan, shown here, actually targets the HER2 protein. And we've learned recently that there may be some patients with triple-negative breast cancer or HER2 low breast cancer that might benefit from this particular targeted agent. So lots of exciting development going on in this space. I will say it's really important to watch for side effects from treatment. And as you've told us, understanding the benefit and the risk of treatments is important in decision making. So if you develop side effects or symptoms, reach out to your care team. They want to know. They can help to get you feeling better sooner and intervene and make sure that you're able to receive treatment in a safe way and feel your best. So it's important to communicate your medical history before you start any therapy. Report out any medications that you might be taking, and that includes over-the-counter medicines. It includes supplements that you might be taking, because there can be some interactions between over-the-counter medicines and supplements. And even with the best of intentions, they can sometimes cause trouble. It's important to know what to expect. Ask about those side effects. Ask about timing. Ask about severity so that you can be fully informed and make appropriate decisions and choices along the way. Your doctor and your care team can adjust the dose, adjust schedule, use supportive medications, all to help treat those side effects so that you can get the greatest benefit you can out of the treatment. And be sure you know how to best contact your care team. So obviously calling the office, who to call after hours. Do they have a secure portal system or email system? You want to be sure you're able to do that in a secure way and that you know how to escalate and what is just not appropriate for email, right? There should always be somebody available to you and your needs. So I think this is a perfect opportunity to stop hearing from me and us, but instead hear from some patients who've lived this journey. So we're going to hear from Barbara, Nikki, and Yolanda on their journeys through treatment and their side effect management.
The type of treatment that I decided would be best for me in my lifestyle and with being a mom and a wife was to choose a bilateral mastectomy with reconstruction. And I did follow that with chemo, 4 months of chemo, a total of 8 treatments. And I believe the cycle was every 2 weeks. There were other options presented to us. My doctor did a really good job of presenting everything from start to finish. But I just, at the moment in time, and my husband was very supportive. We just went with what was told to us that this, if you do this, then it's a less than 1% chance of reoccurrence.
So I'm very happy that we went with the surgery first. We did a lumpectomy and then the chemo, and then we did the radiation.
I didn't really have much choice because when I went to the oncologist, first of all, I never even heard of this kind of breast cancer. I just thought breast cancer was breast cancer. So that was a shock right away. Then he told me that the only thing really available to me was chemotherapy, a radiation, and a lumpectomy. Well, the surgeon told me about the lumpectomy. So those were the 3 things that were available to me. So it sounded like, so I just followed along.
So going through treatment at that time, the only real side effects that I experienced, and I really think that my mindset played a lot into it to help combat some of the worst case scenario. I still got dressed every day. In fact, some of my medical doctors kind of remind me how, I came in as if nothing was wrong, as if I wasn't sick. I just really kind of had a mindset that I was going to live my life as best I could based on the circumstances. And I really think that prevented the side effects. The only ones that were beyond my control would be at the timing that I was getting treatment, which happened to be in flu season. And so, and with, my exposure to my family, my immediate family and what they did and getting their care and going to work, I did have some times whenever my blood counts would be a little bit too low and the chemo would be questionable. And my doctor and I would talk about that and ultimately persisted forward because it was kind of borderline. But it was after a discussion of if we do this, this could happen. And again, I just I'm in my mind, I had a focus of I have to stay on the regimen. I don't want to, extend any time and just stay focused on getting through it.
They did discuss some of the side effects. However, they didn't discuss the full side effects that I could possibly have. They did talk about, like during chemotherapy, I could have, and radiation, it could cause some nausea, just different minor side effects. What I'm finding is they never discussed with me the long-term side effects of going through chemotherapy and radiation.
I started to get neuropathy, peripheral neuropathy in my feet. Hands were okay, but feet, no. I can't. To this day, I'm having trouble putting shoes on. And we're talking about a year out now. Still having difficulty. I have a weakness, some kind of weird weakness in my left leg, which I have to see a neurologist about because I know it's all related. I don't know what that's called, but one of those drugs, or possibly both of those drugs, cause nerve damage. And this is what I'm dealing with now.
So that was so powerful to hear that from patients who've experienced these treatments and have been through this decision making. Ricki, I'm wondering if you could share with us through your work with Touch, what are some of the comments that you've heard from patients? What are the biggest challenges and what might be some of the concerns about even trying some new investigational therapies?
Well, Dr. Traina, in the Black community, there's a lot of hesitation about clinical trials and, research that, drugs that haven't been approved yet by the FDA. And it's such a scary disease, TNBC. So we're doing really a lot of work, and we're going to actually speak to this later in the presentation to help educate about clinical trials and make Black women everybody feel more comfortable with them, to understand kind of how the science works, that no, there is no sugar pill in cancer research, and that you are going to get really, really great care. You're going to get standard of care and possibly something better in combination with standard of care to help you heal and get rid of this cancer. So, I think it's just really being open to finding therapies that are going to work for you and listening to your doctor and really asking your doctor for the best care that they can give you. Like even saying, Doc, what would you give your mom? What would you give your sister? What would you give your daughter? So I think just making people feel comfortable with the research. And because we have such limited options with TNBC relative to other breast cancers, we need to be open-minded to find the best treatment for us. So we're trying to make that happen.
That is so wonderful. Thank you for sharing that. I think it's, important to also put into context that if your doctor or nurse practitioner offers a clinical trial, that is an appropriate option, whether you have early stage breast cancer or advanced breast cancer, and that it is not a signal or a message about concern and that all options have been exhausted, that there are some really great trial options for early stage curable breast cancer where we're just trying to make things even better than where we are today, right?
Yeah, for sure.
So I think we actually have another polling question for the audience. So if you qualified for a clinical trial how likely are you to participate in it? Very likely, likely, not likely, very unlikely, unsure, but open to having the discussion. And we're going to come back to these results in a few moments when everyone has a chance to answer. So I think this is a great opportunity to just sort of talk about exploring clinical trials and what they are. And I know Dr. Wilson's been able to join us. Hi there. I'm wondering if maybe you might want to set the stage and help to understand, what's the difference between a phase 1, 2, 3 trial.
Thank you so much for the opportunity. I'm glad to be here. I had a little trouble getting on, but here I am. It's interesting that as a surgeon, my part in discussing the care of the patient really is usually initial. Usually patients come to me first. We try to make sure that we cover all of the basics. We always recommend that there's a second set of ears there because it's more important for you to have the information and to be able to discuss it than not to remember oftentimes what may have been brought up. So always good to have someone. From a clinical trial standpoint, I work in an environment where almost predominantly all my patients are of Black or are part of the diaspora. And so we spend a tremendous amount of time talking about the role of a clinical trial, as well as what is considered standard of care. And so it's important for our patients to go through the process, understanding each step. When we talk about clinical trials in their phases, the phases of clinical trials really depends on the type of care that's going to be given, and as well as what options and opportunities that a patient has. From your standpoint, Dr. Traina, have you had or noticed a difference in how patients respond to clinical trials, whether it's phase 1, 2, or later phase?
Yeah, thank you for that question. So I'm actually excited to see that the poll respondents said that the majority said they were very likely to participate in a clinical trial. And, I think that is a huge part of related to education about what clinical trials are, right? It is unethical to have, a sugar pill or leave somebody untreated. That does not happen. And in many ways, patients are followed even more closely when they're on a clinical trial than standard of care. So you could argue that the care within a clinical trial is potentially even better because you're so closely monitored and watched. And I think it's important also, and education is out there to say, look, you enter into a clinical trial giving your consent or participation to be a part of it. And you also at any time could step away for whatever reason, right? That you are not bound once having consented to the clinical trial.
That is such an important point, that you have the autonomy to direct your care. You don't get put into a trial and then you have no options to say, this isn't working for me, not quite what I expected, and to be able to step away. What I find in most of my patients is that if they're asked, they are interested in clinical trials. And so the data I think that we have currently is sort of mixed data. They're definitely, when we trial and we are inclusive of all groups, what we find is that there's probably higher participation rates than when they are not, patients are not educated about clinical trials for whatever reason. Their patients' care team may think that they may not be interested, or it's a very complicated clinical trial, so it may be more difficult to participate in. I'm a breast cancer survivor, and Ricki Fairley knows that, and I've been through clinical trials, and would say that a clinical trial actually saved my life and has given me longevity. And so understanding that it is probably care that is above and beyond. It is much more than what you would normally get in your scans and in your follow-up. And in that, you have the opportunity to potentially have a better outcome. And that's what we're always trying to do. We're always trying to make sure that we are providing the best possible care for our patients and making sure that they are participating in all the decision making. So I think it's key to know that the decision making really remains in your hands as a patient. And we are part of the team. We are here to educate and to evaluate and to give you all of the resources that you need to be your best.
So beautifully said. It's so true. And unfortunately, I think that Black and Hispanic and Latina women are underrepresented in clinical trials, right? Only 5 or 6% of oncology trials are representing women who are Black or Hispanic or Latina. So we need to be not making any assumptions, offering these opportunities to patients, and our patients are ever more educated. There are resources that I know Ricki will speak to later about having, a support network and awareness of what's going on out there to even bring that to your care team to ask. We're going to I just moved the slide forward to just see some information and some quotes here from leaders in the field about clinical trials for Black African breast cancer patients. And really, we are so often extrapolating the data from trials to FDA approved agents, and yet we don't know how representative they are if we don't actually have the right women involved in these clinical trials. I am going to actually leave a little bit of moment here to take a look more about this in the When We Trial initiative.
Black women have done amazing things to better our community. So guess what, Black women? We need you to do an amazing thing right now. We need you to do amazing work right now around the science of Black breast cancer. We need you to go to our website, whenwetrial.org, and we have a wealth of information about the basics of clinical trials and why it's so important. We need for you to know your bodies. We need for you to talk about this with your children, talk about this with your daughters, your sisters, your mamas, and the men in your family. We need you to be committed to knowing how important this science is. We don't want to die anymore. We don't want anyone to die. We need to advance the science. Black women deserve better science, better care, and better drugs.
That is just great. So I'm going to turn this over now to Ricki to actually discuss collaborating with your care team.
And Ricki, I just want to say how much I love your campaign. It is
Thank you.
Target and so inclusive. And when I see it, it just warms my heart. So thank you so much for all the hard work that you put into making this accessible and relatable. And hopefully it will drive our community to understand that there's so much more available for us to be our best.
Yes. Thank you, Dr. Gloria. I love you for that. Thank you so much. We're working really hard. So I'm going to talk about a care team. And I've done a lot of thinking about what health equity really means. We keep saying the words health equity. We keep talking about, diversity in care and getting representation and all these things. And to me, it's when a doctor treats a patient like their family. And I know that you two guys, I see you every day working that way, but it's almost demanding that kind of care from your doctor, saying, I want you to do for me what you would do for your mom or your daughter or your sister or your auntie. And it's really about shared decision making. It's about understanding what's at hand. It's a tough disease, TNBC. And most of them have never heard of it before. So really, being open and saying, this is how I feel. And this is how, what are going to be the best things for me to do to make my outcome better. So, clearly defining what's at hand, what kind of treatment I want to do, setting goals. And the goals are, I want to live my best life, right? I want to live my best life during treatment and after treatment, and then making that happen. So it's really important, though, to be open with your doctor and know your own body, know how you feel, and express that and tell the doctor how you feel, so you can have really open and honest conversations about your care. And it's okay. I always say, never go to the doctor alone. And it's been really tough during COVID to not have somebody there with you, but keep a notebook. And, I'm not really good at notebooks, but I just record everything on my phone. And, I do FaceTime with people if I can't bring somebody with you. But make sure that you sort of keep a record, because really, especially when you're first diagnosed, once you hear that C word, you have cancer, then it's like, wah, wah, wah. Everything, nothing else comes through the conversation. So try to take notes, but you may not be able to do that for yourself. So bring somebody with you to do it with you. And then also, before you go to the doctor, make a list of questions. And we have a lot of resources for that. We have those on our website. We have those on the TNBC Foundation website. What kinds of things should you be asking your doctor? I know we work with Dr. Mo to come up with a list of questions, so we can always help you figure out what those questions are. And again, bring a friend, bring a family member, or put them on FaceTime or Zoom. And then, think about, stay abreast of the research, stay abreast of this knowledge. Like seminars like this are so good to learn more about what the possibilities are, what the options are for yourself. And we're always here to help you find those options. And we talk about them every week on our show, which we'll talk about a little bit later. And then, take care of yourself. Take care of yourself. Whenever someone calls me and says, I just got diagnosed with TNBC or with any breast cancer, what do? I say, go take a walk, go outside, go look for God all around you. Go find something bigger than you to focus on, because it's such a scary thing. But then, eat healthy foods. We all want to eat the fried chicken and the mac and cheese. That's not always good to eat it every day. Eat it in moderation. Eat a lot of fruit. Eat a lot of vegetables. Walk. Be outside. And, talk to your doctor about side effects. Like if you're not feeling like walking, if you're not feeling good, the doctors can give you some things to manage those side effects so you can be your best person and be your best life. Chemo and treatment and radiation are not fun, but you just have to sort of make the best of it. And actually, my doctor said, watch a funny TV show every day. So at 2:00, I would eat chocolate and watch I Love Lucy. I'm dating myself now, but I think find things that make you laugh, that bring you joy. And, I had to learn that my peace is non-negotiable. And not only did I have to get rid of the cancer in my body, but I had to get rid of the cancers in my life. Some people that don't give you joy, you need to be around them right now. So take care of yourself, take care of your mind, take care of your body during this time. And, that should go on for the rest of your life. You shouldn't get cancer to find your peace in your life. So I think we're going to hear from our friends, Barbara, Nikki, and Yolanda again, to hear how they're coping with the impact of TNBC and their quality of life, living their best life.
My quality of life after my original diagnosis, it was kind of almost like a rush, because initially I wasn't going to tell anybody. I have a good friend, that I've been dealing with for a long time. We're really close. And when I told him I wasn't going to tell anybody, he was like, that's what's wrong with Black people. We don't want to share. You don't know what kind of support you'll get. You need to let people know. But because I didn't really know a lot about cancer, initially when I heard the word cancer, I'm thinking, okay, that means associated to death, burden, I don't know. I just thought real negative, because I had lost an aunt to breast cancer. Me and her had the same diagnosis, and that's how I ended up at the second organization, because she did her treatment there and they took so good care of her. And we had the same exact type of cancer.
I think this is a really important question about things that impact a patient and their quality of life while they're going through treatment. Because the patient really is solely focused on surviving and beating the status quo. At least that's kind of what my mindset was. The quality of life concerns were asked of me, I think, in a piece of paper or verbally almost every time I went. I'm sure that I was vocal because I'm one who doesn't typically not speak my mind, and sometimes that gets me in trouble. But also it has been a way for me to get the right treatment because I know my body, I know myself, and I know what I need, and I'm not afraid to ask for it.
After I got the diagnosis, first of all, it was an absolute shock because there was no, like I said, you couldn't feel it, you couldn't see it. Only the sonogram found it. The mammo didn't even see it, which was really interesting. This was right against the chest wall and very, very tiny and deep. I was so angry. I was angry for, I bet, about 2 months. I was really, really angry. I don't know why. I can't explain why, but I was just angry. And then I guess it resolved itself. And I said, you know what? I'm going to do what I have to do to get myself right. And that's what I did. You just have to muster up whatever resources you have. Family was super supportive, which really helped. Friends, super supportive. Doctors, great. So I was really lucky all the way down the line, except that I had the cancer, which is very unlucky. Because it really was like the luck of the draw.
I did reach out to my team members and let them know how I felt. And actually, I'm glad you asked that. At one point with my doctor, and I have to be honest, she was really phenomenal with my treatment. So I'm not saying that she wasn't. But at one point, I reached out to her and told her I would start feeling like I was a number. And I sought out a third treatment. I talked to someone else. And although I'm sure they would have taken care of me when I did let her know my concerns, me and her talked, and she just explained to me that I wasn't a number and that she apologized that I felt that way. And I ended up staying with her, and I'm glad that I did. So communication is key. If you feel like something is not right or you have any questions or clarifications, it is okay to ask because she let me know that that wasn't the case. But I had to also remember I'm not her only patient. And by me being a new cancer patient, I wanted her to hold my hand every step of the way. And that's just not how it works. And so I'm happy that I did communicate and be a big advocate for myself. The support that I got, a lot of it came from me praying, just saying positive affirmations every day, telling myself that I'm a cancer survivor. I recited that every single day. Every day I woke up, I thank God for allowing me to be here. And I just said affirmations. I did reach out and ask for support, but it wasn't until after I was done with treatment. But during treatment, just family, friends, my treatment team was very supportive. And I had a good friend who was very supportive. She took me to all my chemo appointments. We fed off one another. If it was something I didn't understand, she was right there being a big advocate for me. And believe it or not, just total strangers. Like I was in Ross one day and I don't know why I told this lady I have breast cancer and I'm going through treatment. And she was like, oh my God, I have breast cancer. And I just was very vocal about it. So I went from not wanting to tell anybody to just being very vocal about it. And it seemed like, strangely enough, everybody I met that I told I had breast cancer to, they start saying either they had it or they had a loved one that had it. And we exchanged numbers and we kind of formed a bond, if that makes sense. So it was, that was strange to me. I didn't know so many people went through breast cancer because people don't talk about it. And some people said they felt shamed. So I'm grateful that, I don't feel shame at all.
My team of doctors actually were very instrumental in helping me at first because, at first I was just like, I'm not sure what I want or even what makes sense and at what time that makes sense for me. And so very early on, one of my doctors really identified another patient close to my age with the same kind of scenario that I had going on and connected the two of us, with permission and such. And so we are still friends today and we started, in the chemo room, not knowing each other. and both, fairly new in our marriages. And then another person that I met in the chemo room, actually, I'm still friends with that person as well. And so those two really, I think, were my core. I think the three of us working together to beat a disease, although different for each of us, helped us kind of form a bond and encourage each other to kind of take the next step each day. In addition to that, I wouldn't be where I am today, living on the other side of the disease, if it wasn't for my medical team.
For support, it was mainly my family, friends secondarily. I didn't do any support groups until a year later. I don't know why, I just didn't. Oh no, there was one person. Somebody told me that she had triple negative breast cancer, and she was the mother-in-law of somebody I knew. So I called her, and she was really good.
So now I'm going to talk a little bit about some resources that are available to you. Of course, I'm going to talk about Touch, my foundation, the Black Breast Cancer Alliance, and our website is here. We actually do a web series every Wednesday night at 6 p.m. Eastern time on the blackdoctor.org Facebook page, and it's called The Doctor Is In. And we talk about everything and anything breast cancer. My co-host is Dr. Monique Gary. She's a breast surgical oncologist in Pennsylvania. So join us every Wednesday night. We also have a list of these different support opportunities here below, but our number is there. If you call us, we're always here to listen. And then we also have the National Breast Cancer Foundation. They also provide resources. Their QR codes are here, so you can learn more about their library, their financial assistance they give, and more about TNBC altogether. And if you want to learn more about clinical trials and have access to them, it's really, really tough. I know there's a website called clinicaltrials.gov. It's like going to hell with your hands tied behind your back. It's very, very difficult to manage. So we try to make it easy for you by going through the portal here with our partner Citizen. We also, on our whenwetrial.org website, have 3 portals into clinical trials specifically for triple negative breast cancer. There's also on the Triple Negative Breast Cancer Foundation website, tnbcfoundation.org. So all of these things are resources available to you. And you can always call us. Call me. I answer the phone 24/7. The number's here. And we will be able to try to help you out to find a trial that works for you. So why don't we jump to questions? We don't have a lot of time left, but I know there's a question about eligibility. Dr. Traina, can you take that one for me about trial availability?
Sure, happy to. I think clinical trials have certain specific inclusion and exclusion criteria built into them, and largely that's around safety. And the criteria will link to really the phase of the study that you're looking at. So if there are exclusions around liver function, kidney function, bone marrow function, it's all with the intention of being sure that a very new drug with maybe limited information around it is not going to pose high risk to folks. And there has been a huge effort to ensure that the criteria we're writing into these clinical trials are as open as possible. We do not want to be overly restrictive. And that is something that I think the academic community is much more aware of.
Great. We have a question in the chat from our friend in Atlanta, Marquita Bass. She says, when there is a family history in an African-American family and genetic testing is negative, could there be something else going on? And I throw that one to you, Dr. Lori. What do you think about that? I think there could be, but I'm not a scientist.
So, unfortunately, there are things that we know and there are things that we don't know. And that's why research is so important, especially when we're talking about genetics, right? We know that when we think about genetics, we think about it being passed from one generation to the next generation. And that we are then looking to see, are there any abnormalities in your gene profile that put you at risk for a particular type of breast cancer or a number of of cancers? And so when we don't find a genetic cause, we know that in the bigger picture, genetic influence is about 8 to 10% of our patient population. So it's not a large population of patients, but we still need people to be involved in the research, being involved in potentially providing their information, providing potential participation for tissue, allowing us to talk more about it, and then being more inclusive of those groups that we don't know as much about. So I believe that there is a link to not knowing enough because we haven't spent as much time working with those groups. But even still, there's still information that we don't know, and that's why we need research, and that's why we need an open and hopefully a group of Black women who are willing to participate and give their information so that we have more information and we know more.
Great. And we just need more research. That's why I try to fight for every day, kind of advancing the science, especially for Black bodies, because I do believe that we're different.
And normalizing research and letting people understand that everything doesn't have to be research is a lot of things, right? Research could be just giving your information about your family. Research could be giving tissue that is automatically going to be removed anyway for your surgical procedure, and donating part of that tissue to a repository so that research can be done. It could be a number of things that aren't particularly related or linked to being part of a treatment plan. And all of that is necessary, and all of that is important.
Yeah, for sure. We have a couple of questions from a friend, Colleen, but I'm just going to ask one because we're running out of time. But she asked, why is it so difficult to qualify for a trial once you're metastatic, and especially if you've already been in a trial?
And so I'm going to have Dr. Traina answer that. I think it overlaps with some of the information she gave already about wanting safety. But I experienced the same thing when I initially was looking for trials, because I had a number of things going on at the same time. But Dr. Traina, can you jump in and give us ideas?
Yeah, absolutely. So, I feel the pain of that question because I share that. There are many times that I wish I could have my patients on a particular study only to find that they're excluded because of perhaps a past line of therapy they had or the number of prior treatments that they've had. I think in some ways, when a new drug is being investigated or there's a question around the benefit of a treatment, if someone has had a very similar drug, we may not see the benefit of that new intervention. And so the trials are designed to both make sure they're safe for patients and also give folks sort of the best chance at having a benefit from therapy as well. I would say don't be discouraged and keep at it and keep looking and keep asking. And it may be that your doctor, your hospital may not have a study that's a good match, but you can look beyond that. And we are a big, warm, supportive academic community, and we want what's best for our patients. So, I speak to my experience at Sloan Kettering. I'm happy to reach out to my friends around the country looking for the right study and a good match for my patients. So just keep at it. Don't be discouraged.
And I've watched her do that many times. I've sent many patients to Dr. Traina, and she's gone through hoops for them. So I guess we're out of time. Thank you so much for joining us today. Thank you so much, Dr. Wilson and Dr. Traina. You are my super shero doctors. Thank you to our audience for this special patient education program. And thank you to the National Breast Cancer Foundation and to Touch the Black Breast Cancer Alliance for partnership on this program. Support for this patient education program was provided with an educational grant from Gilead Sciences. Thank you for being our partner. And please remember to complete the questions at the end of the program to help reinforce some of the topics covered today. You'll see event resources section of the player located under the video box to download today's presentation, slides, and additional resources you'll find. I hope they find them helpful. And the program will also be available on demand on Cancer Coach Live. So thank you. Thank you again. My name is Ricki Fairley. I'm glad you joined us. Be safe, be blessed. And for my TNBC breast sisters, stay strong, fight like girls, and live your best life every day. So thank you for joining us.